It's really good to see you.
Yeah.
Are you fit and well?
Yeah, touch wood, yeah.
I had a chat with Professor Hooray down in Wales. As you
Yeah.
know, as you may recall, I've worked with him for 12 years and produced all manner of colorectal media content. And we're chatting about COVID. But I wanted to talk to people that I've worked with to see how, you've got through it and coped. And also the key thing is how we're going to get elective surgery back up and running and what your views on that is. Because I think that's the key. Everyone's talking about it and no one really can put their finger on how to do it effectively and safely.
Well, we've started. In fact, we didn't stop doing our cancer surgery. We made the decision that we weren't going to take the college guidelines. We weren't going to stop laparoscopy. We weren't going to give everybody a stoma. And we just carried on. So we did 20 bowel cancers I think in 3 weeks, and no adverse effects. I think the majority of them were laparoscopic. I think 3 were open, and they all were fine. And what we did, I don't know how much of our hospital you remember, but the mothership hospital that you come to, Whiston.
The Whiston, yeah.
Yeah, but we have if you like, a satellite hospital as well, St. Helens Hospital, which is absolutely beautiful. It looks a bit like Charing Cross, it's very glassy and
nice.
And we do our day case surgery there, and we do a lot of our clinics there. And there are a couple of wards there, the day ward. And so we came up with a policy whereby we would make that our cold site. So there's no acute stuff there. So there's no COVID there. So we moved all our colorectal surgery there, and we set up the 6 of us that work in colorectal, and we split into 2 teams. And alternate weeks, we have the theatre and we have the ward, or some of the ward. Urology are doing the same with their cancers, and breast are doing the same with their cancers. So it's like a little mini cancer hub now. And we were the only people on Merseyside doing cancer surgery. So what we did was, it's amazing, isn't it, in these times, that what used to take 6 months of committee meetings and things like that, you have the idea in the morning, there's a discussion in mid-morning, and by lunchtime it's a plan, and by evening time it's actions. It's been amazing. We contacted the Cancer Network, and they agreed that we would do all the bowel cancer for Merseyside because nowhere else was doing any. They'd all just packed up. Anyway, all that. So we set up the whole process, and that just put everybody to shame to a large extent. So all the other hospitals then started opening up their service. So now we're in the situation whereby we've caught up the bowel cancers, but we've got surgery, we've got theatres 5 days a week at St. Helens. So now what we've done is we've looked at our waiting lists and picked the urgent cases. Now, you can't do quite as many as you would do in the past because it's a bit of a palaver, because we still have to wear PPE, COVID type PPE. All the patients are tested that morning, and they come in at 6 o'clock, they're tested. So by 8 o'clock, we have an answer. And so we've just started doing the non-cancer urgent elective stuff. So next week I've got 6 AWRs to do next week, and everybody's doing the same. The people are going through their lists and saying, look, these are urgent, we need to do them.
So Mike, that's really encouraging. But all the patients you were talking about, they were all emergency cancer patients that you were dealing with, yeah?
Not emergency. They were cancer patients. They weren't emergencies. They didn't present as emergency. They come through the system, if you like. They'd had their investigations, and they were lined up for cancer surgery when it all stopped.
So what about all the diagnostics work during COVID? Were you able to do all your CT colons and your
well, okay. So you know as well as I do that there was a load of hysteria, okay? And what happened was that we realized that people were identifying what they thought were aerosol producing procedures, and they were stopping them. That was why people attempted to stop laparoscopy.
Yeah.
But we realized that the X-ray department had said they were going to stop CT colons, and that the endoscopy department said they were going to stop endoscopies. So we pointed out, look, if we're doing the surgery, you can do the diagnostics. And again, it took half a day, and the appropriate people spoke, and the appropriate people were spoken to, and now we have CT colon service. Takes a bit longer, of course. We have a CT colon service, we have an endoscopy service, and again, they're happening in the cold site. The tap is opening again. Admittedly, it's more of a drip than a torrent at the moment, but it's happening and it's working. But now, you see, when we started this cancer hub thing, we could only do cancers. And now that they recognize that they're going to have theatres stuffed, wards stuffed, and we've got urgent patients, we've started to do that. And equally so, and I don't know the people you've spoken to, whether this happened to them, but from our outpatient point of view, we stopped seeing new patients across the board, routine new patients.
Yeah, that seems to be the majority of scenarios.
Okay, so we've turned that round now as well. I mean, all of our follow-up work was being done over the telephone unless patients were having a problem, and then we offered them face-to-face, as in face-to-face in the room, not face-to-face like this.
Yeah.
And then for the new patients, just last week, we've now started booking clinics for face-to-face consultations. And okay, there are some limitations because of social distancing, but it's the start.
How do you, you say you have Whiston and then the other hospital?
St. Helens, yeah.
Yeah. How do you prevent staff from cross-contaminating? Because obviously if they're working in one and then working in another, have you got dedicated staff that are working in just the other hospital? How's that working, Mike?
Right. From the ward point of view and from the X-ray department point of view, and I think from the X-ray department point of view, certainly the radiographer side of it, and from the theatre staff, yes, what they did was they moved the colorectal nurses that had specialist knowledge and skills from Whiston to St. Helens. Yes, yeah. Just on Saturday they were working in Whiston, and on Monday they were working at St. Helens. I heard last week that NHS England were bringing in a programme where everybody on frontline surgery was going to get tested for COVID every 2 weeks. So now, I'm not sure how public that is just yet, but the fact that NHS England have suggested it, and our hospital are certainly going to do it, then that suggests that that's a way of allowing the doctors who are between the two sites to still work between the two sites.
Yes.
I mean, a significant number of the department have had it anyway. Yeah. I think 3 of our consultants and probably about 3/4 of our registrars have been COVID positive and are back at work now. I mean, I'm very, very fortunate. I work for a very proactive trust, and with no shortage of PPE, or not the kind of shortage that I'm hearing about in other hospitals, and everything is on the table. So we were very, very quick at doctors who weren't perhaps right, or they had partners at home who weren't right, boom, went home straight away. And then when the testing came in with a bit more ease, they were all getting tested as quickly as possible. It's been fabulous. We set up into 2 teams, a red team and a blue team. And although we didn't give people time off, we made it such that people that wouldn't normally work together made a team, and it's been really, really good. Two of the surgical wards became COVID wards, but they've now been stood down. One of the surgical wards was made into a ventilator ward,
Yep.
but never had to be, touch wood, has never had to be utilised.
Good.
Our intensive care unit was able to cope all the way through. We never had to use recovery or this surgical ward for ventilation. So although we had a lot of people at one point. I think there were 160 people in the hospital who were COVID positive patients. We never spilled out of our 20 ventilated beds in ITU. So we were, in some ways, we were very fortunate. In general surgery, we feel it's that the shoots are there for the elective work. Obviously, the private hospitals are all closed, and as you know, most private hospitals survive on, or previously survived on, performing NHS work. That's all ceased at the moment.
Yes.
But there has to be green shoots there as well. And I know that my local private hospital is currently under the auspices of NHS England. Right. But on the 28th of June, I'm led to believe it goes back to being a private hospital. So it'll be interesting to see what happens, whether that allows us to perform some of the cold elective work that, which will help keep things ticking over. It won't be perfect, but it will help things tick over.
I know it's an almost impossible question to answer, but you see things changing, and you're starting to build up a new portfolio. How do you think your work practice will change in the future? I mean, permanent change. What do you think will happen? Or do you think we'll all in 2 years' time be back where we were? Will we have a new normal, or will it be the old normal?
I think we will have a new normal, except that's the unpredictability of it, isn't it, really? That I think people are always going to be conscious of some degree of social distancing and some degree of screening. But it very much depends on what happens with the disease, doesn't it? That if this disease disappears, or disappears in its lethal form, then things will go back virtually to normal. But if this is a seasonal thing, then nothing can return completely to normal. But people do have to have treatment of their conditions, be they surgical, medical, whatever, orthopedic. People are going to have to continue to have. So it may be that ultimately we have hot hospitals and cold hospitals. I don't know. I mean, we are in a perfect situation in our trust by having a hot hospital and a cold hospital already, but it's not the exclusive answer. No. And they're going to have to, people are going to have to think out the whole process, from referral to outpatients to inpatients to theatre. I was talking to the manager in charge of outpatients globally in our two hospitals, and she was saying her problem is that they want to open the clinics, but so that they can ensure that social distancing is kept, they're having to make the waiting areas a third as many seats there. Yeah, that they can't have as many nurses in the clinics. And it is going to be difficult, and they're going to have to limit the number of people who can come into the room. And so I think that those changes will have a long-lasting effect, going back to your original question.
When you think that A&E worldwide is down between 40 and 50%, it'd be interesting to see where that goes, because people are staying away for various reasons. Suddenly it's all fine and dandy. You'll get this massive influx, and then
it just goes to show that in the accident and emergency departments throughout the world, there are the genuinely sick, and that there are people who aren't that sick. Sadly, there's probably a third group of people who are sick but are staying at home. But I suspect they're a relative minority. certainly in our hospital at the moment, the wait time in A&E is 15 minutes. And so probably countrywide or England-wide, the 4-hour target is going to be achieved for the first time ever for years.
I know.
And the other thing we have in our emergency department is we have almost like a hot corridor and a cold corridor. So anybody who potentially could be COVID positive or is COVID positive goes one way, and all the people who have no symptoms and have come with something else go a different way, and the two generally don't meet. So I think that what it's made hospitals and doctors and nurses look at their practice and the ways that they can improve it. Now, if that's the sort of thing that carries on, that would be good. Although, if COVID just dies away, or this particular COVID dies away and doesn't come back in a different form, in a similarly lethal form, then I think ultimately things will go back to almost what we consider as normal. But if it becomes a seasonal thing, then Lord knows, this could change medicine forever.
I know it's a slightly existential question, but how has it changed you, Mike? Has it changed you?
No. Yeah, it hasn't changed me as a person. What it's done, and this is me personally, because the private hospital is closed, then I suddenly have 20 hours a week on top life that I never had before. It makes me realize how ridiculously hard I was working. And what I used to have to do was work 6 weeks and then have a week off because burnout was approaching. Now I could work forever like this. You know, I've cancelled all my holidays. I don't need any time off. I'm rested, you know. So it's had a hugely beneficial effect on my life, in that my work-life balance is significantly different. But has it changed the way I look at disease or the way? No, I'm champing at the bit to be back, you know, on the type of operating that I was doing before and the volume of operating I was doing before. So no, and I think that it's quite interesting. I was going to say, at no point have I been frightened about this. Right. Except there was one day, it was Good Friday, and our surgical ward was turned into a COVID ward, and we were all the consultant surgeons and urologists who used that ward had to come to work on Good Friday, and we were told, this is going to be the weekend where it takes off, and on Monday you will be looking after the wards, you will be looking after the ventilators, you will be doing. And it was a bit of a scare tactic, I think. And as it happened, it didn't ever come to fruition. But that day, I remember going home on Good Friday thinking, God, this is serious, you know. And I don't think I was frightened about it. But it's funny, when I look around the hospital, there are some very frightened people.
Yeah.
And it hasn't had that effect on me.
No, that's good. I think for me,
so.
Looking at the Nightingale hospitals, when you think, you know, the one down in London, in 9 days, a potential 4,000 bedded area in the Excel was built. I think it's shown again that we can do pretty much anything when we have to do it, and when our minds are set and when the focus is there. All this procrastinating and going through years of trials, and all, we can do things really quickly when we put our mind to it.
The same thing with when there's the Nightingale they set up in Manchester as well, in the conference facilities. It is amazing.
Thank you for your time. Just before we round it up, is the you know, what's going to happen? Are we going to get this second wave? What's your gut feeling?
I think there will be a second wave, but I'm certainly hoping that it won't be like the first wave.
Mike, it has been absolutely fantastic to speak to you. Thank you so much for doing this. I know you've done loads of other things, but thank you so much. True inspiration. Thank you for all what you do. I really do appreciate it. And I know everyone else does. So thanks, Mike.
You're welcome.
Cheers. Bye-bye.
Bye.